أوكي. ممكن دكتور مهدي تعمل مشاركة السكرين شيرنج، نعمل تيست إلى أن نبدأ
آه.
الوقت. ممكن
كيف؟
نعمل تيست للسكرين شيرنج
تيست. أوكي،
الآن نبدأ
ممكن.
الوقت.
أوكي، ممكن هذه. دبورما. تشوفوا فيها.
ممتاز جدا. بيرفكت.
أوكي. شوفوا فول سكرين.
أي نعم.
شكرا.
برزنتيشن ممتاز.
أوكي.
أوكي. فريقه. Dr. Hugo still trying to connect, so still have
يقول
a
not
photo.
yet دكتور يوغو.
Yes, not yet. I'm contacting him now on WhatsApp. He is trying to connect now. He should join us any minute,
أوكي.
inshallah. See here. Professor Hugo, can you hear me?
Yes.
Yes, okay, that's good.
Uh, so can you help me to open my camera?
Yes, I think you can open the camera.
But the
Try to open camera from your side.
the host, yeah, it's that host doesn't allow me to open the camera.
Ahmad, can you hear me, Ahmad? Please, if you can make Dr. Hugo a co-host and allow him to open his camera.
Yeah, and I'm sorry for the late and now at the midnight in Beijing, and I'm just finished an emergent surgery. So I didn't take my laptop, so I connected with my phone. It's a little bit inconvenient. I'm sorry for that.
No, no problem. We are on time now. We still don't have any delay until now. So it's already okay, I think. Ahmad, can you hear me, Ahmad, please? If you can make Dr. Hugo a co-host and allow him to open his camera.
Yeah. So can we start?
Yes, Professor, you can start welcoming the audience and we can start.
Okay, so now I'm making an opening remark, and good morning or good evening, everyone, and very warm welcome to all the young neurosurgeons, esteemed colleagues, and guests joining us from across the globe for today's webinar, and we have. This is a weekly webinar organized by Yemeni Neurosurgical Society in collaboration with the WFNS Young Neurosurgery Forum and Pakistan Society of Neurosurgeons, the Neurosurgery Couch, and the Neurosurgical.tv. And today we are honored to invite the Professor Dr. Mahadi Damo, and he is the professor and the HOD of neurosurgery, Monastir University, Tunisia, and the president of the Tunisian Neurosurgery Society, the president of Magharibian Federation of Neurosurgical Societies, and the president-elect
Arab.
Welcome, Dr. Mahdi. Dr. Mahdi
Thank you.
Talmol,
Yes,
we'll talk today about the anatomy of the optic nerve, of the chiasm
Thank
and
you.
visual pathway.
thank
So,
you.
Dr. Mahdi, please, you can start.
Thank you. Thank you very much. First of all, I would like to thank the organizing committee and especially Professor Ahmed Saleh Jaradi and Professor Yeo Gio from Japan. We talk about
China.
from China. Sorry,
Yeah.
from Professor
That's okay.
Diego from
Okay.
China. Sorry.
Yeah.
Thank you very much. Thank you very much. I will talk about anatomy of the optic nerve, chiasm, and visual pathway. We'll start. The visual pathway extends from the retina and to the cortical center of vision. And they have three functions: reception, transmission, and perception. And we can distinguish two parts: extracerebral part and intracerebral part. They start from retina, from the first cell neuron is from the bipolar cell, then the second from ganglion cell, to the third neuron in the lateral geniculate body and project to the visual cortex in occipital lobe. And we start with the extracerebral optic pathway. We distinguish the retina, the optic nerve, the optic chiasm, and the optic tract. And the retina is a nervous membrane of the eye that lines the inner surface of the back of the eyeball, composed of 10 layers. And the visual system here we can see the optic nerve starting at the posterior part of the eyeball, passing through the orbit, then entering the optic foramen and continuing through the optic canal to reach the middle cranial fossa. The optic nerve is a whitish cylindrical cord of about 1 million of nerve fiber with the 3 envelope, 4 portion. The optic nerve is really an extension of the central nerve system and not like the habitual nerves. And here the optic canal is a short, bony tunnel in the lesser wing of the sphenoid. It connects the middle cranial fossa with the orbit. It contains the optic nerve and the ophthalmic artery and lies just medial to the supraorbital fissure. And to put it in a nutshell, this figure shows the 4 anatomical segments of the optic nerve. We have intraocular part, which is with 1 millimeter of length, intraorbital part, between 25 to 30 millimeter of length, intracanalicular part in the canal of the optic nerve, about 5 to 9 millimeter of length, and intracranial, the last part, the intracranial part, 10 to 16 millimeter. Here, the fore part of the optic nerve from the posterior part of the eyeball to the intracranial part, in which he will join the opposite optic nerve to form the chiasm. And here the relation of the optic nerve with different structure in the orbit and in the canal and in intracranial part, relation with the oculomotor muscle and also with vessel. Here image of MRI showing the optic nerve in the orbit, in the canal, and in intracranial part of the optic nerve, the second cranial nerve will join the opposite nerve to form the chiasm. Here also we see the fore part of the optic nerve and the vascularization of the optic nerve, the arterial supply by the ophthalmic artery, which is a branch of the carotid artery, and the drainage with the central retinal vein and the superior ophthalmic vein and inferior ophthalmic vein. And they join the cavernous sinus, and they reach at the end the cavernous sinus. Here, the envelope of the optic nerve. The optic nerve is surrounded by 3 layers: the P mater, the subarachnoid space containing the CSF, and the dura mater. It is not like an habitual nerve with endoneurium, perineurium, and epineurium, but with 3 layers: pia mater, subarachnoid, arachnoid layer, and arachnoid mater and dura mater. And here the normal case, but in case of increased CSF pressure, the space of the CSF can increase in diameter, and here we can have intracranial hypertension, and this can result in fundoscopic by papillary edema, which can go at the end stage to the optic atrophy. We can see also other pathology of the optic nerve and the optic disc. We can see central retinal artery occlusion. Here we see this aspect in the fundoscopy. We go now to the optic chiasm, the third part of the extracerebral portion of the visual pathway. White is a white quadrilateral band in the shape of an X with 3 morphological types: the dimension, the transversal dimension from 12 to 14 millimeter, the sagittal from 5 to 7 millimeter, and the thickness from 2 to 4 millimeter. And this chiasm exists in the inferior surface of the brain. And here we can see the anatomic variation of the chiasm. There are 3 anatomic variation, post-fixed and normal and pre-fixed chiasm. 3 anatomic variation. Here in the sagittal view, in axial view, normal aspect of the chiasm, and prefixed aspect and post-fixed aspect with long optic nerve. Here the optic chiasm, the 2 optic nerves join to create the optic chiasm, and the optic chiasm lie in the chiasmatic sulcus of the sphenoid bone. Here we can see the optic chiasm, the relation of the midbrain, and is created by the connection of the 2 optic nerve, and we can see here the optic chiasm, an operative view, another view of the optic chiasm. The blood supply, especially by the anterior communicating artery, the anterior cerebral artery, the internal carotid artery, and especially the branch of the internal carotid artery, especially the superior hypophyseal artery. You can see also the relation of the chiasm and optic nerve with the suprasellar structure, especially with the vessel, and also with the pituitary stalk and the mammillary body. And here the optic with the floor of the 3rd ventricle, the optic chiasm also forms part of the floor of the 3rd ventricle. Anteriorly and superiorly, it is related to the lamina terminalis, which connects to the rostrum of the corpus callosum. Posteriorly, it is related to the infundibular recess, which is continuous with the pituitary stalk. Here, other view of the optic nerve. Here, the chiasm in close relation with the pituitary stalk and the pituitary, and here in close relation with the floor of the 3rd ventricle, with the hypothalamus, and with the lamina terminalis, and with the pituitary gland. Here, other view of the optic nerve and the chiasm in the inferior surface of the brain. Here, frontal view of the chiasm. Here you have the ACOM and the infundibulum and the superior hypophyseal artery. Other view of the chiasm with the 2 optic nerve and the relation with the vessel carotid artery, A1. Here, the arrangement of optic fiber in the chiasm. The fiber from one optic nerve, the temporal fiber, remains in the same side and will join the ipsilateral optic tract, but the fiber from the nasal part will cross the midline and join the opposite optic tract. And also the fiber from the macula also will cross the midline and join the contralateral optic tract. Here we have the temporal fiber remain in the same side, but the nasal fiber will cross the midline to go to the contralateral optical tract. Here, if we have a lesion of one optic nerve, we can have a blindness of one eye, and if we have a lesion of the chiasm, we can result of bilateral temporal hemianopia. Here, the optic chiasm is not merely the junction of 2 optic nerves. It plays a pivotal role in binocular vision by enabling the integration of visual input necessary for image formation. Due to the optic lens, the image is reversed on the retina And well, the image of the right visual field will be based on the signal sent by the temporal fiber of the left optic nerve and the nasal fiber of the right optic nerve, all of those connecting to create the optic tract and then joining the left primary visual cortex through a pathway, through the radiation. Here we will talk about the optic tract. Optic tract continues the posterior angle of a chiasm with a length of 3 centimeters. It is carried in the lateral part of the bishak cleft, goes around the cerebral peduncle and ends in the geniculate body, in the lateral geniculate body. Here, the optic tract refers to a band of fiber consisting mainly of axon from retinal ganglion cell, presenting a continuation of the optic chiasm. It is located along the upper anterior and lateral surface of the cerebral peduncle surrounding the midbrain. It ends by dividing into two roots, external large optic fiber and internal small acoustic fiber. Here, the optic tract ending in the lateral geniculate body. Here, if we the lesion of the optic tract result in lateral homonymous hemianopia. The blood supply of the optic tract come especially from the posterior communicating artery and the anterior choroidal artery. Now we will talk about the second part, the intracerebral optic pathways. We have three parts: the lateral geniculate body, the optic radiation, and the visual cortex center. We start with the lateral geniculate body. The lateral geniculate body is an elongated ovular structure located on the lateral surface of the cerebral peduncle below the pulvinar. It is connected by the anterior conjunctival arm to the anteroquadrigeminal tubercle. And the lateral geniculate body are diencephalic structure considered as thalamic relay nuclei lying on the posterolateral surface of the thalamus, lateral to the medial geniculate body. It receives optic tract fiber from the contralateral visual field of both eyes and gives on optic radiation to the primary visual cortex via the temporal Meyer's loop and parietal pathway. However, a minority of this fiber will bypass the lateral geniculate body to terminate in the pretectal nucleus to participate in the pupillary light reflex and the superior colliculus for the regulation of saccadic eye movement. Now we will talk about optic radiation. Optic radiation connecting the lateral geniculate body to occipital cortex. They correspond to the third diencephalocortical neuron. They have three portions: retrothalamic surrounding the anteroexternal part of the pulvinar, retroventricular portion, and juxtaventricular portion at the level of ventricular junction. It divides into three bundles: a dorsal bundle, a central bundle, and a ventral bundle. This is the optic radiation from the lateral geniculate body and terminate in the occipital cortex. And the optic radiation originates from the lateral geniculate body and extends into the calcarine feature in the occipital lobe. Because the lateral geniculate body is part of the thalamus, the optic radiation emerges as fiber of the posterior thalamic peduncle. And the blood supply of this optic radiation comes from deep optic artery, from posterior cerebral artery and calcarine artery. Here, the Meyer's loop is the anterior portion of the optic radiation. Here, the Meyer's loop. The anterior portion of the optic radiation that sweeps forward in the temporal lobe, arching around the lateral horns of the ventricle. Because it carries superior visual field information, temporal lobe lesion can result in a contralateral superior quadranopia. we have the anterior bundle, the central bundle, and the dorsal bundle. The anterior bundle, which is called Meyer loop, travels anterolaterally along the roof of the temporal horn of the lateral ventricle prior to taking a sharp turn inferiorly around the temporal horn of the lateral ventricle. The anterior, here the ventral anterior bundle or Meyer loop. The anterior bundle then track backwards deep to the superior and middle gyri of the temporal lobe, remaining lateral to the temporal horn and terminate in the inferior lip of the calcarine sulcus. The central bundle initially traverses, this is the central bundle, traverses laterally over the roof of the temporal horn of the lateral ventricle prior to sharply turning posteriorly and continuing laterally along with the occipital horn, of the lateral ventricle, and terminate in the inferior lip of the calcarine sulcus. And the dorsal bundle, this is the dorsal bundle, tracks dorsally and posteriorly separated from the lateral wall and roof of the occipital horn of the lateral ventricle only by the tapetum. This posterior bundle is relatively superior to both anterior and central bundle and terminate in the superior lip of the calcarine sulcus. Here, the dorsal bundle. And here we can see the Meyer loop or the anterior bundle, the anterior fiber, representing inferior retinal quadrant, superior visual field, and here the dorsal or superior fiber, representing superior retinal quadrant, inferior visual field. And here the representation of the field in the retina and in the occipital cortex. Here we can summarize the blood supply of the optic radiation. The anterior Meyer's loop vascularized by anterior choroidal artery, the middle portion by anterior choroidal artery plus middle cerebral artery branch, the posterior portion by the PCA, the lateral geniculate nucleus vascularized by anterior choroidal and thalamo-geniculate branch of the PCA. Here we come to the visual cortical center. This visual cortical center is located in the inner surface of the occipital lobe on either side of the calcarine fissure. It comprises two areas, the visual area which occupy both lips on the base of the calcarine fissure, called striate area or Brodmann's area 17. The visuopsychic area of visual gnosis, divided into two parts, peristriate area or area 18 and parastriate area or area 19. Lesion of area 17 results in crossed homonymous lateral myopia. Bilateral lesion of area 17 results in cortical blindness, and lesion of visuopsychic area results in visual agnosia. This is the cortex area 17, and this is 18 and 19 in the external surface of the brain. And in the internal cortex of the brain, we have the calcarine fissure. Above and below, we have the visual area, and V2 are the psycho-visual area. Here we can see the optic nerve in this anatomic specimen, anatomic nerve, and optic chiasm, optic nerve, optic chiasm, optic tract. And here the lateral geniculate nucleus and primary visual cortex, and here the optic radiation. You can see the optic radiation. This is the optic pathway from the retina to the optic nerve, the chiasm, the optic tract, the lateral geniculate body, the lateral geniculate body, and the optic radiation to the visual cortex. Here also we see the fiber of from the optic nerve here, the optic nerve coming from the posterior part of the eyeball, and the chiasma with decussation of the nasal fiber, and here the optic tract and the lateral geniculate body. In the lateral geniculate body start the third neuron, represented by the optic radiation, which join the occipital lobe in the visual cortex below and above the calcarine sulcus. And you see here the optic pathway in the MRI. In the diffusion tensor imaging MRI, we can see the optic pathway, the fiber from the optic nerve, the chiasm, the optic tract, the fiber in the lateral geniculate body in the optic radiation, and ending in the visual cortex. Here also the DTI of the brain. Here we have pituitary tumor which compress the chiasm, and you see the fiber compressed by this pituitary tumor. Here, the visual pathway from the retina to the occipital cortex is a precisely organized system. Each part plays a key role in vision, and damage at any point causes specific localizable visual deficit, making it crucial for both anatomy and clinical diagnosis. You can see here all the visual pathway from the optic nerve to the occipital cortex, the primary visual area, and the damage of different parts result in this lesion in the visual field. Here also a lateral view of the different visual pathway and visual progression of the information from the visual field progressed through the retina to the optic nerve to the optic tract to lateral geniculate body and the optic radiation below and over the sulcus, the calcarine sulcus. And here lesion of visual pathway in different location. And here we can see explain the reflex, visual reflex. The papillary light reflex begins with light stimulation of the retina, which sends signal via the optic nerve to the midbrains, pretectal and Edinger-Westphal nuclei. This nuclei then activate motor neuron. This is the afference, and this is the efference after activation of motor neuron of the oculomotor nerve, the third nerve, which causes the pupil to constrict here, and we have construction of the pupil due to the light, which is the pupillary light reflex. How the progress the information through this pathway visual system is comparable to a photographic system. The lens is the crystalline and the film the retina. Light passes through the cornea, the aqueous humor, the lens, the vitreous humor, reaches the pigment layer of the retina and will be transformed by photochemical reaction into stimulation at the level of the cones and rods. The nerve impulse passes to the bipolar cell, the ganglion cell, the second nerve, then the optic fiber reaching the optic nerve, the chiasm, the optic tract, then the lateral geniculate body, where a third neuron transmits this nerve impulse to the to the occipital cortex. And here the progression of the information from the lens, the eye, the retina to the occipital cortex. Here in the lateral view also the progression of the information, and here we can see the upper part of the field is projected in the lower part of the occipital lobe, and also the lower part of the visual field is projected in the upper part of the occipital lobe. Also here, the progression of the information of the image through the reversed by the lens in the retina and the progression till the visual cortex. And here we can finish with a small video. This is a patient of 38-year-old with complaining of visual disturbance. She has suprasellar meningioma compressing both optic nerve. After the resection of this meningioma, we can see the different structure of the supracellular region, especially the optic nerve with their relation to the supracellular structure. We try to, yes, here, operated by right pteryginal approach. Here we can see the right internal carotid artery. Here the right optic nerve, and here after the resection of the meningioma in this part, here the pituitary stalk, and we can see in the left side the left optic nerve. We see that this is the left optic nerve. And here the below we can see the ophthalmic artery, and here the epiphyseal superior epiphyseal artery, and here between the optic nerve and the carotid, and deeply we have after opening the Liliequist membrane, we can see the basilar artery. This is the close relation of the optic nerve, optic pathway in the middle cranial fossa with this structure, especially with the vascular structure and the pituitary stalk. And thank you for your attention.
Thank you very much, Professor Mahdi Dermol, for this very nice presentation and very nice information. Please, if anyone of the audience have any questions, please, you can put in the chat so we can answer it. Dr. Trigo, can you hear me?
Yes, yes. I'm sorry for the inconvenience, and I during the professor's talk, I disconnected because the bad connections, and but I hear the most part of the professor's lecture, and thank you, Professor Mahdi, for the masterful and enlightening presentation, and that was an incredibly comprehensive overview of anatomy of optic nerve, optic chiasm, and visual pathway, and in some specific cases. And the professor have given us a great think about, and more importantly, to apply in our own practice. So, is anyone to have some questions and comments about Professor Mahadi's talk?
I don't see any questions here in the chat. So if
Yeah,
anyone
we
have
can
any questions,
discuss about.
Okay, go on, doctor. Professor?
Yes.
Dr. Seri, do you have any comments?
Professor Mahadi, and
Yes,
I
yes, I
have
hear you.
yeah,
Yes,
yeah. I'm sorry, I cannot open my camera, and
no
I
problem.
cannot see. Yeah, I cannot see the other participant of this webinar. So, about the suprasellar meningioma, you just showed us the case. So, do you use the nasal transsphenoidal approach to resection such cases or specific cases to remove the tumor below
Yes,
the optic nerve and optic chiasm?
yes,
Did you do that approach?
Yes, I did some for some cases for some small meningioma, tubercular cell meningioma, less than 3 centimeter, and the endonasal approach with the endoscope is good to not damage the optic nerve and supply, especially, and the small perforating artery is good, and we have a good result of visual improvement with this approach transsphenoidal from below than from above, from transcranial habitual approach. For small cases without encasement, and I did for some cases this approach. Yes.
Yeah, because the transsphenoidal approach, the challenge is the skull base repair after the tumor resection. So, um, uh, so how do you compare the transcranial craniotomy approach and transsphenoidal approach? Do we because I performed some such cases, but three at least three cases I redo the skull base because of the CSF leakage.
Yes.
So yeah, so I'd rather to do the craniotomy to remove the trans how to say that um, the eyebrow uh, eyebrow incision, the minimally invasive craniotomy. So what's your experiences?
I think the transcranial approach is the approach of choice for all suprasellar meningioma. But in selected case, in small cases, we we can do this transsphenoidal endoscopic approach for some selected case. Yes, no, for small cases without encasement. But the supra, I think for my experience, the transcranial approach, perinal approach is a good approach for to resect this meningioma.
Mm-hmm. Yeah. And another question is in the terminal approach for suprasellar lesion. What is your most reliable landmark to safely identify the optic nerve when it is severely distorted by a large, like a tuberculum celli meningioma or a giant aneurysm?
What is your question?
The
Question?
because when we do a large tuberculum celli meningioma or
Yes.
a giant aneurysm, the anterior circulation and aneurysm, the large aneurysm, the optic nerve, it might be severely distorted by the tumor or
Yes.
angioma. So what is the most reliable landmark to safely identify the optic nerve and to protect the perforating vessels supply the nerve and chiasm during the dissection.
To protect, we can we do transcranial approach, of course, but we can also open the optic canal to the optic canal, and we can do craniodectomy also. Many things we can do to protect the optic nerve, and we should maybe through the opposite side. Start with the opposite side and
Okay.
and keep the optic nerve at the end, maybe.
Okay, I got it. I got it. Thank you. Thank you so much.
Okay.
And Professor Ahmed, and because I cannot see the participants of the webinar, so is anyone to have comments and questions?
I see in the chat box, but there is no anyone have any questions. And I think you can open your camera now, Dr. E. I make you a co-host, and you can see the participant from the participant button. We have here Dr. Mu'tasim Al-Asali. I think this informative lecture. Okay, he has a question. Thank you for this informative lecture. In case of compressive optic pathway pathology like tumor, in which percentage of the patient could improve after excision and decompression if he had visual defect pre-op? I think he's asking about percentage of patients that have improvement in vision after surgery. Dr. Mahdi?
If we have compression, only recent compression, we can have very good improvement. But if we have in the fundoscopy grade 4 of papillary edema or atrophy, there is no improvement. If we have papillary edema in the first stage, we can have improvement of visual acuity and visual field and all the.
So you say that it depends
If we
on
are
the
late, the improvement
yes.
is not very well.
So it depends on the
The
timing and the
percentage is
severity.
very low if we are late. If we treat after. If we are late, if we treat early this meningioma with early sign of compression, we can have good result in visual field and visual improvement. Good result.
Thank you. Usually here in Yemen, most of the cases we see late cases, so they come after months after
Yes.
decrease in vision. So we have
Yes.
very little improvement in these cases.
Yes.
Okay. And I have a comment about to give some message to young neurosurgeons. And like the Professor Mahadi's lecture, the anatomy and applied anatomy for some crucial neural pathways is for the young neurosurgeons and the residents. We have to practice to learn from the real surgery and the cadaver practice. But the cadaver resource is limited. So now in my center, we are trying the augmented reality. I think we are developing with this method to the young neurosurgeons learning and practice and um, uh, navigation during the surgery. Now we are developing this system with our university. So I think this might be the next generation's learning method. And after we using this method to get some impressions, and then we practice on the cadaver, and then to in the real surgery, so might shorten the learning curve. This is what I thought about the improvement of the young neurosurgeons.
Thank you, Dr. Hugo. I have a comment also regarding your previous question or comment about identification of the optic nerve during surgery. Usually, as we do, we try first to identify the optic nerve while it exits from the optic canal next to the carotid artery, and then we open the optic canal and remove the bone. We drill the bone over the optic nerve, and then we open the falciparum ligament to lose the optic nerve and to allow little manipulation without damaging of the nerve. What do you think, Dr. Mahdi?
Yes, I think we should attack the tumor before from its base to reduce the volume of the tumor and to debulk. Maybe we enter in the meningioma and debulk, and with reducing the volume, and at the end we will see we should rest in the tumor. We will see the optic nerve, and yes, we should identify the optic canal and the roof of the optic canal to identify the optic nerve and the carotid artery also behind the optic nerve. Yes, I think yes, we should identify the optic nerve. Yes.
So usually, doctor, when we have a big tumor, which side, if you do a terminal approach, you go from the affected side or from the contralateral side?
We
If
both are
if one eye is
are
more affected
debated.
than the
Yes.
other. Yes.
Me personally, I go with optic nerve, the bed optic nerve, in the side of
Okay.
the bed, the bed
The
optic
worst
nerve.
one. Yes.
Yeah, the worst one. Yes.
We do the same.
Yes.
So, Dr. Hugo, do you have any final remarks before we concluding of our session? Professor E, do you have any final closing words? We don't have any questions here in the chat, and I think there is any more questions. So maybe you can say the closing word, Dr. Hugo, for today's session.
Okay, so no more questions and no more comments, and so I would like to once again to thank Professor Mahadi for the excellent lecture and the discussion. And to all the young neurosurgeons who joined us today, I hope this session has inspired you and provided you with practical knowledge you can take forward. And so, thank you very much, and thanks for the Professor Mahadi, and also thank Professor Ahmed invitation. So so maybe we can close this session today.
Thank you very much,
everyone.
Professor Iogiu, Professor Ahmed Salah Al-Jaradi. Thank you very much for your kind invitation. And it's an honor for me to participate to this session, this educational session. Thank you very much.
Thank you very much,
Okay,
Professor.
thank you very much.
And I think with this, we can conclude our today's session and see you all, inshallah, next week, next Friday, with more speakers, inshallah. Thank you, Professor Mahdi, for this fantastic presentation.
Thank you. Thank you. Thank you.
Thank you. Bye
Thank
bye.
you. Bye.